Hello and welcome to the Pain Podcast. I'm Tim Beams. I'm host today and founder of Scientifique, and I have Bart Van Buchem, pain specialist physio and co-founder of Le Pub with me. And also, I think relevant for this topic, we're going to talk about FND. So spotlight on functional neurological disorder today. And it's an area where you specialize. So Bart has a special interest in functional neurological disorder, and we're going to dive into some of your specialist knowledge. And particularly today, the flavor is around powering up recovery through physical therapies.
Yes. Well, couldn't agree more.
So the first thing that we wanted to just talk a little bit about is a lot of people probably don't realize that physiotherapy has a place in the treatment of FND. So why is that? I mean, what's the block there at the moment?
Yeah, well, it's just a little bit of a history on FND would be, if you just check out you should just do a Google search right now. Pause the podcast and check out a Google search on hysteria, and you will find out that the name of FND wasn't always been FND. Obviously, it's been hysteria, it's been conversion disorder, so it's going through the ages, and as primarily a female health issue. Which obviously wasn't true, but by the time it was the hysteria as a label for when symptoms has converted into something like it was obviously like a psychiatric disorder, and I'm not going into the details because we will have our FND program that will be released. Probably really early next year or this year. I'm not sure when we're going to publish this podcast, but early 2025, you will learn lots about a bit of history, because it's important to understand that it's come a long way, and it's primarily a psychiatric disorder has been labeled within the DSM. But I think like about a decade ago, they decided that conversion disorder is not, and hysteria obviously was already left a while ago, but it's that was not the suitable term. It was not the right term, because conversion basically says it's translated to something, and we now know it's not always translated from a psychiatric problem or issue that arises, and therefore people have motor symptoms like loss of, let's say, motor control, loss of their feeling, their limb, or seizures. About 30% to 40% did not meet. It's not meeting the criteria, but do have functional symptoms, and therefore saying they don't have anything. That's not helpful for people. And not helpful for psychiatrists, is not helpful for neurologists, because people will sort of they will just flip around and just getting lost in translation. And John Stone, a neurologist from Edinburgh, who we also have had on the pub, has been probably one of the main frontiers of making this change, as his research has shown that we have to revisit the criteria, and that's happened. So the DSM-5 has changed the name to FND and then / conversion disorder, but the next one will be, the conversion will be left for sure. But in the criteria, it doesn't say you need this psychological, let's say, conflict as a minimum criteria, like inclusion. So and that's massively important, because that's arising, that it moved to a more neurological diagnosis, because we basically diagnose by what we see. And that's obviously that people have motor symptoms or sensory loss or seizures, which are typically neurological disorders. And it will be the doctor, the medical specialist, well, people will be looking for when they have. So visiting your GP will probably referring to a neurologist if you lose feeling or have loss of or impairment in movement, which is also makes it more accessible. And I think the main reason why physical therapists nowadays are more, or physiotherapists are more involved in the treatment of FND is because it's used to be a psychiatric disorder and diagnosis, and now it's a neurological diagnosis. And therefore, physiotherapists may have been involved, and I know they have always been involved in the treatment, but depending on the type of healthcare system you work in, the mental health department is not as, let's say, not as biopsychosocial as you would think or would be helpful. And therefore you can see this distinction. It's either mentally issue or it's physical, like a soma department. And I'm pretty sure that every psychiatrist or psychologist who working with people with what would be used to be conversion disorder would absolutely see people can benefit from movement strategies, because that's how it works. But getting physiotherapists involved has opened up a whole new era, and therefore more accessibility for treatment. So people don't need to be admitted to or need to be sort of patient in a psychiatry department. So they can also have treatment for FND with not being in the mental health department as a part of their treatment, which I'm not saying it's not important, because it's hugely important, because there's a majority of people with FND also have mental issues. So it would be very helpful for them. Perhaps it would be very helpful for them to have both approaches available, which I think FND therefore is right in the middle of the biopsychosocial. So it's split. You can't get away with just purely making it psychiatric, and you can't say it's purely a mechanical issue or even like a brain function thing. It's not just that. It's typically right in the middle. That's why you need to understand both areas.
Can I? So, and then thanks for that. So there's a sort of, let's just say, a historical perspective of hysteria. I mean, even the word hysteria sort of evokes, something in me of like what you're exposed to as you're growing up, that someone's hysterical. And you can imagine then what that might do to other people as well in their expectation of what this might be. I wanted to play a devil's advocate here, because I mean, we're saying physiotherapy or physical therapies, but I wouldn't see your role as purely being based on understanding and treating from a movement perspective, because you obviously have skills. You have your psychological therapeutic skills as well, don't you? And I'm just thinking, if you lost the awareness or the ability to be able to move, or you had these tremors that were part of the experience, that must be hugely scary for some people.
Absolutely, yeah. It's quite diverse. So FND doesn't capture the let's say the diversity, because it could be basically any type of neurological, like loss of sensory information, but also the experience of walking. It could be a very specific movement. It could be very task specific. So the diversity is massive, and therefore you can't say this is a typical FND patient. Although what you could say is that you once you see the patient, you have to take it all on board, right? So there might be fear, there might be unknown, there might be incapability of changing it, might be context that's super important. People might be traumatized, but not all of them. And I think the most important thing is that we used to label this as a trauma induced problem. Let's say about Freud, who's basically written a lot about this, about conversion, because the name came from Freud, his work. So therapists will be mainly focusing on what's the trauma. And if you don't know about any trauma in your life, you will have to figure out where it is, actually, because you were probably not aware of it. So that's a very strong direction of treatment. So psychiatrists wouldn't necessarily be interested in the movement disorder. The patient actually is. So my experience is people are worried about the loss of function. And may not be related to anything else, which is maybe you're right. It might be correct because there might be no traumatic event at all, because that's about 37% does not have a traumatic event. So therefore you have to be aware of that it could be anything. But the main concern for the patient is that they have loss of function. And it makes sense to connect with the patient, to take that seriously, listening and see if you can sort of do something about that. And that's, I think, where physiotherapy is key, because we are pretty comfortable in movement strategies, motor impairments, motor control. That's our area.
So can you summarize where you would see your role with someone presenting with FND? Are they coming to you with prior diagnosis as well? So like, where are you in the journey, and what is it?
Yeah. That's a great question, Tim, because I think there is some, I would say that you need the diagnosis, and ideally the diagnosis is being made by a neurologist, because they can rule out other neurology, like degenerated issues. For example, when you're trying to figure out whether it's a functional trauma compared to Parkinson's disease, that's typically the area of a neurologist and not a physiotherapist. We can have an educated guess, obviously, but we are not in the position to do that. And I think it's especially great when you collaborate, when the neurologist ideally refers to the physiotherapy with this diagnosis. And therefore, you can start treatment pretty much straight away. And that's where I'm positioning us as a physiotherapy, with a referral. I would be slightly uncomfortable when people did not see a neurologist, or maybe just a GP who is not really comfortable and not trained to make this distinction. And I think that's pretty key. And interestingly, when the neurologist has diagnosed FND, it's very likely that's correct. So that the uncertainty is not, like I said, there's only a 5% of misdiagnosis in FND once the diagnosis is set, which basically means it's not lower than multiple sclerosis, and it's not worse than Parkinson's disease. So it sort of creates a more stable fundament to start your education, to start figuring out how you can improve movement, because there is I would say you could have a more positive prognosis with FND compared to Parkinson's disease, depending on the stage. Does that make sense?
Yeah, absolutely. So sort of just summarizing that is, it's very, very usual, typical, or you want really someone to have come through a diagnostic route of having seen a neurologist. When they make a diagnosis of FND, then usually it's pretty bang on.
Absolutely.
Pretty, certainly certain to get it right. Very unusual not. So we're starting in a place of confidence then, aren't we, of where my treatment fits in. So
Yeah.
then let's talk about that then. So what does that look like in terms of your relationship with your clients, and what are you, yeah, how are you working together?
So the referral would be nothing more than a referral from any kind of disorder you would get. It wouldn't be very different, though. You have to check with your patient whether they are comfortable with the diagnosis. Do they understand it? Do they actually believe it? We've learned that people who do not accept the diagnosis are less likely to improve whatsoever.
Okay. Yeah.
So, and the acceptance of this diagnosis is much greater when a neurologist has discussed it. But you cannot necessarily expect the neurologist has got hit the sweet spot. If they did, it's great. You just reinforcing. If they not, you just probably have to go through a procedure where you sort of checking out and maybe start treatment by saying, well, this is typically fitting the diagnosis because you're improving now. This is unlikely to happen in Parkinson's disease. There are strategies actually that can actually be very helpful there to make this distinction, as, because it is mainly fear driving. Well, it might be something else. The other way would be like it's all in the head, right?
That old helpful one.
Yeah, oh, absolutely, and it depends on how it's been introduced. Although people do see it's not a peripheral issue, so you could easily say that, well, actually, this is a central neurological issue in a central neurological issue, and therefore disorder. And you can easily say that because it's actually, we know it's there, and it's sort of a mechanistic, approach towards, and we know that central neurological disorders are affected by what's happening in the brain from any perspective, as well as social, environmental, and also psychological things. And people would, and I don't find too much resistance there. What I do see when people have uncertainty about, for might it sort of turn out to be an early stage of multiple sclerosis, or might it be an early stage of, which I can't deny that it's not like 100%, because it might turn out at some point, because these generative diseases or disorders are obviously, that's hard to diagnose them like on a one time in place. You probably just have to follow up on the long term. So I would say comfortably say, when we go through the procedure with the neurologist, people would not necessarily dismissing it, especially when you start focusing on their primary problem, and that's a motor problem, and people would typically they would absolutely feel comfortable going that direction, as it's their main issue, regardless what they think about it.
Mm-hmm.
So that will be, if that makes any sense in the context of treatment.
So I've got a question for you then, and we've talked about the potential relationship crossover within nociplastic pain of FND and CRPS, complex regional pain syndrome. And you said about the obvious emphasis on the central nervous system with FND. Do you ever get signs like you do in CRPS of changes within the tissues, like the autonomic signs or the trophic signs, as alongside your motor signs, or is that more of a rare or unlikely phenomenon with FND?
Oh, that's a great question. My first answer was it will be different. You won't see the trophic changes whatsoever. What you would see if you test sensitivity, for example, by pinprick, you would think, like, if it's something that if the neurologists basically have shown the peripheral nerves are working through EMG, then you would expect then some of the pinprick. At some point, they will sort of present some pain experience. But I've repeatedly did that with people, to be honest, just to make sure and how it works, just finding and experiencing how people go through like pinprick and like seriously doing it. And you can see you can't fake it. It's just important. It's just impossible to fake it, as some people will have loss of feeling, and it will basically no feeling at all. I'm not sure what would happen if you basically proceed having a surgery procedure there, but when by just pinpricking, they're giving very noxic, like a very strong nociceptive input, they won't feel it at all. So, and that's if that's what you're asking for, is there something objectifying that? Well, but you
Which
will
would be very different, wouldn't it? You so often with CRPS, it's a gain in function, a sensory function. So
yeah,
increase in awareness.
it will be So I would most of the case you will find a loss of sensory effect, but there will be, in some cases you will find an increase, but I'm not sure whether that's necessarily related to FND itself.
So I want to geek out on this for a second, if that's all right then.
Yeah.
So that's a really interesting observation. And then is that a regional thing? Is that just within one limb? Is it a whole body? Is it on one side of the body? What's the presentation like?
Yeah. So the presentation will be very unlike, let's say, the dermatomes. It will be the whole leg, or just the foot. It will be just left-sided or just right-sided. Like the hand, it will be just up to the wrist, and then slowly improving the sensory, let's say, experience again when you move up to the upper arm or the forearm. So you have a very, I would say, an non-typical neurological presentation. Obviously, we did have some people like having, well, for example, when you have loss of feeling in the face, and they will, instead of like having people have a stroke, you will find out that they're the area in the what's it called, just below the head,
anterior triangle, the neck.
Yeah, the neck. Sorry, I just figured out the neck.
I didn't know how specific you wanted to get.
Yeah. Sorry. When the neck will be actually, they'll have the same loss. They have the same sensory loss. So that's a way of distincting from a stroke, for example. So people have the whole right side of the face, including the neck, and then the chest, for example, and shoulder. And sometimes it's people like having a paralyzed by, from, let's say, from the belly downwards, but it may have a like an overlapping sort of transition area, and it may even be fluctuating it. And some people, I would find, they do have function in their genitals, but not in the thigh. So that's why I'm just saying it would be quite unlike for anything like that, and it will be a way of distinctive for a neurologist. That's why it's important to have this knowledge of how they're diagnosing other things like stroke and any kind of neurological problem there, which also brings us, like, when you're checking in, you will find odd patterns. Not that they're not in the textbooks for sure. But they are there. You can pinpoint them.
Like a nice classical, like peripheral neuropathic or a radicular symptom, and so then let me just go beyond that, because I'm interested. So from a spatial based processing point of view, will that, if you bring that affected side onto the opposite side of the body, does that have any effect? Or if you change the vision, like relating to that, body part, does that have any effect then?
Yeah, I've been trying out some really funky things. I did have some people who viewed, indeed, if you just bring them the right, let's say the paralyzed side to the left, where it wasn't, and people did experience, they did have different experiences, and sometimes improvement in motor function.
And
And
when you say improvement in motor function, is that
yeah,
an
like they can do
immediate?
more when the limb is moved to the other side. Let's say from this, let's say from the right to the left, they experience more control, which is probably the most at the moment the most evidence based thing you can say about the things that have changed compared to healthy controls in FND is that people have a changed or they have a distorted sense of agency,
Okay, gotcha.
and therefore you would expect that people have a different perception of their body. It could be either that it's a loss or it's changed or it's twisted or it's bigger or it's not there. They don't experience of them, that they don't have ownership over that body part, but not necessarily pain. So this will be different to CRPS, for example, where people just experiencing pain and not experience their limb, it's theirs, but people just, there's nothing, it just doesn't feel like but I do also got examples where people do have pain in
Yeah.
that part. Yeah.
So I guess then the sort of natural progression of this, I'd love to just spend a few minutes thinking about the potential for recovery doing some sort of physical therapy. So if there's a loss of a sense of ownership, or they lack agency of a body part, and they don't have awareness, a sensory awareness of information from the affected body part, how can we work to bring back a sense of ownership or the ability to regain agency of my movements again?
Yeah.
My
So
body.
that's the $1 million question. But actually, this is I can give you, because I do think there is it's something that we can figure out with the patient on a, I would say, NS1 condition, because every person with FND would have different responses to different approaches. But just in a briefly, I would say you would need, or people will be sensitive to attention. So if you drive their attention towards or away from, or basically learning people to that it will change the experience, and you will find out actually that it may cause, or it triggers a, let's say, a motor response, and it will be merely a positive response because it will be more or better than it was.
And by doing that, you could do something like use vision, or you could do a task on another part of the body, or something like that.
Exactly, yeah. Like a tremor, for example, typically would be, is it's a functional tremor. By using entrainment, is basically using the other limb to induce movement, and therefore the tremor will slow down, it will change its rhythm, and people will actually be able to, driving that attention will actually change it, because, and they wouldn't be aware. So that's gaining sense of agency over movement again. So that will be, people will experience that. Wow, that's that could be life changing again. So that's what I've experienced. People thought that it could never ever move again, or wouldn't be able to change it, or to control it or whatsoever, and then it suddenly happens.
And having found that is part of the process to practice, to rehearse, to train that.
Exactly. So giving control by doing something you haven't done for a while, and sometimes it's very contra-intuitive for people. So for people with like walking disorders, functional walking disorders, they might walk backwards, and found it surprisingly easy to do so. And therefore, people will be surprised by doing that, because it's not intuitively, you're not going to think about walking backwards. It usually is harder, right? So by doing it and perhaps even filming it, showing it, and asking for the experience, how they experience, how it felt. That will be sort of the first step in the treatment, and start shaping it. Because people are sort of in F&D they're very strong and very sort of stuck in a pattern.
Yeah.
You would say like expectation in the motor system is basically primed for this. There's no error when people drag their feet. You would expect it would be. It's not. So I would say one of the things is that people are sort of stuck in a pattern, and therefore you're just gonna basically trigger them to do something different, and gaining self agency.
Yeah.
And maybe you need to give them some cognitive control. Just they know what it is. It's safe to move, and it will be education. And for some people, it's very important to regulate their emotions. So when they experiencing fear, you have to sort of look after them very well regarding their feelings of fear and anxiety, which is may driving the condition as well. So I think I've labeled like 5 things now that you have to take in account at the same time. And as I would say, like a successful exercise will be something that consists everything and hitting that sweet spot. And people got that. Like you could call it like a motor or sensory positive experience. And that's the first things for your behavioral therapeutic approach. You can start shaping it. And
it sounds like you need a bit of creativity there then. And
absolutely.
also,
there's no one way to do it. There's you have to be focusing on older patterns. People would love to, they might be dancing around and feel like haven't done it for a while, and sort of people just have to pretend swimming, and you can think of all types of things. So, but we got heaps of examples that I'm going to show in our F&D program where you can actually see it's happening. And that's pretty cool, actually, to be honest. And it's quite obvious. And then you can see how it may shape from there onwards. It's definitely bringing back creativity in the clinic.
Can I try something? Can I just repeat back to you using some maybe some terminology? Maybe it's a bit old. Maybe it's like how some people might think about things. But it sounds like what is a part of that presentation is it's like this movement representation that they're playing out again and again and again, and they've strengthened the connections between different parts of the brain, and we could probably guess some of them, couldn't we? We'd be thinking about the certain parietal regions and motor regions and the interparietal sulcus and what have you that might be a part of that, and maybe the basal ganglia if there's a bit of emotion involved in the movement, and the cerebellum. And so I don't know, I'm just guessing here, but we've got this sort of movement representation that plays out again and again and again, and a part of your therapeutic role is to find an alternate path, an alternate strategy. So the destination's the same, walk, move the limb, but you're getting to it in a different way. And we're trying to build more variability, more flexibility in the way that you get to that end game. Does that sound like it's what we're looking at? Therapy?
Yeah, that would be a nice summary. Yes. We do. It sounds easy, but sometimes can be quite tough, right? Yeah. It's not, and I think that the challenge there is to connect and have a confidence doing it.
Yes.
And because if there's no confidence from the therapeutic approach or from the therapist, it's not going to work as good as it could be. Yeah. As confidence is massively important in this. And basically showing people that actually can do much more, but doing it in a way. And you have to express that confidence. Otherwise, it's not going to be, let's say, helpful. Yeah.
Cool. And I want to say, because, we've talked about certain models to understand things, but you can see where something like predictive processing could explain some of this, couldn't you? Where the confidence and the precision is very high on this specific experience. And
Exactly. Yeah.
It might mean that we're trying to just bring in the potential of other predictions, other expectations, other outcomes. And you need to be really quite creative and sometimes very experimental in order to just bring options onto the table. Yeah.
Yeah, and I know it's been there is a paper called FND and in its Bayesian and predictive processing models as a as an introduction for this, and it has been widely referenced. And people like Carl Friston have worked on that paper as well. So people on the forefront of predictive processing has been part of that. So you can see there's FND lends itself quite nice to fit the model, maybe even better than pain does.
Yeah.
As you can see the change, which is really interesting because you can sort of measuring it. You can objectify the change in movement and not just the experience, but you can basically just film it and see how it changes. So it's pretty cool.
Nice to get some immediate feedback, isn't it? Yeah. I'm afraid we're running out of time. We're going to have to
Well, like always,
do our best to summarize this. So this episode was just putting a spotlight on functional neurological disorder, FND. We've been calling it in all the way through, haven't we? And we wanted to ask the question whether or not physiotherapy fits the process of recovery and we're completely biased, obviously, but we feel that there's the ability to power up recovery through physical therapies. You started to introduce historical perspectives of FND and talked about hysteria and conversion disorder and how we are finally, at this stage of actually accepting that it's more than just hysterical, psychological, emotional, and in some people doesn't even have a traumatic incident that relates to the onset of FND. But a huge part of it is the presentation, how someone experiences themselves with FND. And you discuss the need for the neurologist to do a workup, and for when they do their workup, then usually they are great at ruling in FND and ruling out alternative diagnosis like Parkinson's and MS you mentioned. Although we talked about that, some people will still have in the back of their mind, could it be, is it? And you can't 100% be certain that it isn't a part of this beginning. And as you mentioned about having one assessment sometimes not being enough, maybe you need to have a follow-up and to recheck and be sure whether or not that's the presentation. And then you mentioned about where you sit as a physical therapist, that yes, there's a role in the physical, in the movement, in the behaviors, but there's also the role in you understanding, validating, educating, understanding where fear and emotion might relate to it. And in fact, there were some cool examples that you gave where you were talking about how, for instance, fear might be a part of the presentation, for instance, of tremor in a limb. And actually being able to regulate that can be a part of a therapeutic process. But so could finding alternate movement patterns. So you gave an example of when walking was problematic, perhaps walking backwards may not be. About sort of finding these creative alternative ways to get to where you want to get. We could carry on talking about this all day, couldn't we? And you've mentioned a couple of times, but Le Pub are putting out a short course. We haven't decided what we're going to even call it. I think a masterclass is probably likely, but we've got a few guests, haven't we, coming in and explaining it in great depth. So a neurologist, a researcher, a clinician, all coming together and giving us a real in-depth knowledge of FND.
Yeah, which in my view, we've tested it quite well. So we're doing these live courses for a while now, and like the feedback was like, I think I can start doing this now. So I would expect a very similar experience. So hang in there for a bit, and we will release it, and you will have like a full, there will be a neurologist, a psychiatrist, there will be a physio background, there will be a research background for the motor retraining programs we've developed, and it's quite exciting. So this is like a full program. I don't think you can get it anywhere in the world. So we're putting this together, and it's we're really excited to hear what people can do with it.
Yeah, exactly. So we want to build a bit of hope out there for people diagnosed with FND, don't we?
Absolutely.
Yeah. Awesome. Thanks so much for checking in. If you got to the end of the podcast here, please do share it, like it, shout about it. We want to get some of this information out there for everybody. So thank you very much, and see you next time.
Thank you. Ciao.